Good morning, everybody. Happy Tuesday morning. Our speaker this morning is Dr. Alexandra Walsh. Dr. Walsh came to Phoenix Children's last year from Las Vegas. She's a member of our Hematology Oncology Division, where she's the director of the long-term follow-up clinic. She did undergrad at Cornell University, then medical school at the Ohio State University, and then completed a residency pediatrics at University of Chicago. She then did a master's in public health and her fellowship in pediatric hematology oncology in Alabama before moving on to Las Vegas. Then here at PCH last year, we're very happy to have her, especially as the director of the Survivorship Clinic, where I worked with her as the endocrine component. And her talk this morning is on complications in childhood cancer survivors. Please welcome Dr. Walsh.
We're going to make this a little interactive today, so get out your phones if you want to text your answers in. I just started here, so it's nice to get to know some other people, and I'm very happy to be here. It sounds like I've been a lot of places, but I'm here to stay. So these are the objectives for today. Okay, and we're going to start out with an easy one. What is your favorite breakfast food? So text A if you like pancakes or waffles, B if you're a bacon lover, C for donuts, and D for coffee. So text PCH MEDED 22333 to join, and then A, B, C, or D. Nobody likes pancakes. Okay, good. Okay, looks like we're a coffee-only crowd. Me too. So I wanted to start out with a picture illustrating what we're going to be talking about today. So this is a picture of two identical twins. The one on the right had childhood leukemia at 4 years of age. She received cranial irradiation, and her identical twin sister. As you can see, the treated patient with leukemia is shorter. She also is a little bit more obese, and her IQ is actually lower too, if we could measure that. So I wanted to start with some background information about childhood cancer in general. Childhood cancer is rare, luckily. Total is about 150 cases per million in children under the age of 20. Leukemia is the most common type of childhood cancer, with about a third of all new cases. And brain tumors and leukemia make up 50% of all cases of childhood cancer. Brain tumors are the most common childhood cancer, solid tumor in children. And this is the rate by age of childhood cancer. As you can see, males are more likely than females to be diagnosed with malignancy at all ages by a little bit, and incidence is higher during the first year of life, with a second peak at 2 to 4 years, and then incidence increases again at age 15. So childhood cancer treatment is one of the big success stories in modern medicine. All these different colored lines represent different types of childhood cancer. And as you can see, in the 1940s, the survival rate was only 10%. And by the 2017, we're up to 83.9% overall survival, all types of childhood cancer combined. So this is wonderful, but this does come at a price, and that is the late effects among the childhood cancer survivors. It is important to keep in mind also that childhood cancer is still the leading cause of death in ages 1 to 15. So certainly our battle there is not over by any means. But improvements in multimodality therapies and supportive care have led to the dramatically increased survival rates. Like I said, overall 5-year survival is 84%. 1 in 285 children develop cancer by age 20, And there are estimated to be 600,000 childhood cancer survivors in the United States. This population is growing as our success increases. It's estimated that every high school in the country has 1 to 2 childhood cancer survivors in it. And there are about 3,000 in the Phoenix area who've been diagnosed and treated in the last 10 years. This is a big population relatively. So this is a graph showing the annual number of deaths over time. So the blue line has been steadily going down, and the yellow line is averted deaths. So these are deaths these are patients who are living who would have died if treatments hadn't improved. So in 2007, there were 2,200 children who survived who otherwise would have died. So many of us are familiar with the short-term side effects of chemotherapy, and this is where a lot of the focus is, as we're treating patients. As a reminder, chemotherapy and radiation work by targeting rapidly dividing cells. Hopefully this will be changing in the future where we have more targeted therapies, but right now still our backbone for treatment of childhood cancer is chemotherapy, which also harms healthy cells, which are rapidly dividing also. So that's where you get your hair loss, your mucositis, your effects on the bone marrow, including neutropenia, anemia, and thrombocytopenia. And then we also have nausea, vomiting, anorexia, weight loss, and fatigue. Long-term side effects are different, and these are things that we worry about in the long-term follow-up clinic. We still see fatigue. We see a lot of endocrine abnormalities, including metabolic syndrome with obesity and glucose metabolism abnormalities. We see bone health issues and growth failure in certain patients. We also see cardiac toxicity, pulmonary toxicity, auditory toxicity, school and brain functioning issues, infertility, and then a pretty significant secondary malignancy risk as well. So as we got better with treating children who were diagnosed with cancer, there was this awareness that these patients were having a lot of late effects. So the Childhood Cancer Survivors Study was funded by the NCI in 1994 to understand these late effects of childhood cancer. And this is where a lot of our understanding of the late effects really comes from. This study included survivors diagnosed from 1970 to 1986 from about 20 centers in the United States and Canada, and 14,000 survivors were surveyed and followed for long-term health outcomes with 4,000 siblings for comparison. And their medical records and treatment exposures were recorded, including their surgery history and radiation doses and chemotherapy doses. And then a little bit later, a second cohort was added in the 90s. So one of the first things, the dramatic things that was noted in this study is that we used the 5-year mark to measure our success for treatment of the primary malignancy. But if you follow these survivors out over time, their mortality is actually significantly increased as compared to their siblings. And you can see the childhood cancer survivors on the bottom have a pretty significant drop-off in their survival by 20 and then 30 years after diagnosis. And this is also dependent on the type of cancer that the patient is diagnosed with. So for example, Wilms tumor doesn't have a lot of late effects. So 95% of those patients survive 30 years. Leukemia, 84% of those patients live 30 years. But Hodgkin's and brain tumor patients actually have only 73% 30-year survival rate. Neuroblastoma has a 90% survival rate, non-Hodgkin's lymphoma 83%, soft tissue sarcoma 81%, and bone cancer 80%. So this is very variable depending on the type of cancer that was diagnosed, and then of course the treatments that were received to treat that cancer. So what really are the causes of death? So the blue line in this graph shows you the mortality based on recurrence of the primary disease. So you can see that after about 10 years off therapy, there's no further risk of death from the primary cancer. So it's something else that's causing these patients to die. And then the yellow line is the risk of other causes of death, which increase dramatically over time. Using the second cohort from the childhood cancer survivor study, researchers were able to show that this mortality is decreasing over time. So not only are we impacting our overall survival, but we're also impacting our late effects, which is great news. So in the 1970s, our 15-year mortality was 10%. In the 80s, it was 8%, and in the 90s, it went down to 6%. And that risk from dying from the primary disease went down from 7% in the 70s to 3% in the 90s. And then if you look at other health causes, so these are the late effects causing death, those also have gone down dramatically. So 3% in the 1970s to 2% in the 1990s. So we are seeing some success, but these are still a lot of patients who are perishing because of the treatments that they received or their primary disease. And of course, this is just the tip of the iceberg. So if we look at the total number of patients who survived, that's 82% of all patients survived. But the vast majority of these patients have some sort of chronic medical condition. So 72% will have a chronic medical condition. And these are pretty serious. So 30% have a grade 1 toxic medical condition, toxicity medical condition, 25% have a grade 2, 33% have a grade 3, and 10% have a grade 4. So a lot of these medical conditions are really impacting the quality of life. So if you break these problems down by type of health condition, and you look at just the grade 3 or 4 health condition, and you compare the survivors with their siblings, you really start to figure out which are the problems that these survivors have more of. And so the relative risk of a major joint replacement is 54 times higher in survivors than in their siblings. Congestive heart failure is 15.1 times higher, and the development of a secondary malignant neoplasm is 15 times higher. So I want to spend a few minutes talking about some of the specific side effects that have the most impact on childhood cancer survivors. I obviously won't be able to cover them all, but I wanted to highlight just 3. 1, hearing toxicity, 2, cardiac toxicity, and 3, infertility. Okay, it's time for your second question. So which of the following patients is most at risk for developing hearing loss requiring hearing aids? Wilms tumor, A, optic pathway glioma, B, medulloblastoma, C, and neuroblastoma, D. Give you a few minutes. Okay, so it looks like the majority of you guys got it right. So medulloblastoma is the cancer with the highest risk of auditory complications. So the risk of hearing loss is greatest in survivors who have received both cisplatin and radiation to their brains. Thus, patients with brain tumors such as medulloblastoma are at the highest risk, especially if they were diagnosed at a young age. So auditory complications are fairly common in childhood cancer survivors, and they're very important to diagnose and treat because success in school and socially is really dependent on your ability to hear the teacher and the peers. So if you look at the incidence of dizziness, if you're a childhood cancer survivor and you did not receive radiation or cisplatin, your incidence is 1.5%. For radiation is 2%, and for both is 1%. For tinnitus, if you did not receive either radiation or cisplatin, is 2%. If you received cisplatin, is 4%. If you received both, it's 5.8%. For significant hearing loss, if you received both cisplatin and radiation, your incidence at 15 years is 6%. And for deafness requiring hearing aids, it's a lower percentage, but still significant, and radiation is the biggest player there at 2%. And if you look at your multivariate analysis, which is adjusted for age and sex at diagnosis, the highest relative risk of requiring hearing aids is actually cisplatin dosing at 8.6%, with head irradiation and brain irradiation also increasing your relative risk dramatically. So patients who receive most cisplatin and radiation are the brain tumor patients. So they're the ones that we need to watch most closely for this. Speech complications are also very important to monitor in childhood cancer survivors. So stuttering and stammering was reported in about 4% of survivors. And this is associated in multivariate analysis with brain radiation. And speech complaints are often associated with hearing issues, and both speech and hearing issues make school very difficult. Okay, question number 3. So a 34-year-old female presents to a MedPeds outpatient clinic for a yearly physical exam. You obtain a medical summary of the chemotherapy treatments she received during her therapy from the long-term follow-up clinic. Of the following, the treatment that puts her most at risk of heart failure is the following: vincristine A, daunorubicin B, Cytoxan C, and cranial radiation is D. So PCH, MED, ED, 22333. That was too easy. You guys are too good. So it is daunorubicin. And this is your maintenance of certification question for today. So anthracyclines, which include doxorubicin, daunorubicin, mitoxantrone, and idarubicin, are the biggest contributors to the risk of heart failure. And higher cumulative doses of anthracyclines and younger age of diagnosis, as well as radiation with the potential to impact the heart, such as the neck or the chest, all increase the risk of heart failure development. So heart disease is still the #1 cause of death in the United States, and traditional risk factors include obesity, high blood pressure, physical inactivity, tobacco smoking, diabetes, high cholesterol, and then a family history genetics component as well. And childhood cancer survivors have all of those baseline risks that the rest of the population have, but they're at increased risk for cardiovascular disease due to the chemotherapy, which we just discussed, radiation, and then also if they've had any multi-organ dysfunction during their treatment, such as sepsis and need for pressors. So the signs and symptoms of cardiomyopathy are the same in childhood cancer survivors as in adults. However, it does require us to be mindful of these symptoms. These are not symptoms that we as pediatricians are used to eliciting from our patients or thinking about, our survivors may have these signs and symptoms at much younger ages than in the general population. So for cardiomyopathy, symptoms may be fatigue, decreased exercise tolerance, shortness of breath, swollen legs and feet, fast breathing, dizziness, chest pain, difficulty laying flat to sleep at night. And arrhythmias may present as palpitations, rapid pulse, dizziness, and fainting. So if we go back to that initial slide showing the different increased risks in childhood cancer survivors as compared to their siblings, congestive heart failure was one of the big ones with a 15.1 times relative risk in survivors. And when you look at their exposure, it's really the anthracycline chemotherapy, as I already said, that was most often at fault. And we think it's because the myocytes are damaged or destroyed with the chemotherapy itself. And then the remaining cells try to compensate and hypertrophy. So you can see late cardiac events in survivors, including left ventricular dysfunction, heart failure, and cardiac death. And it may be asymptomatic or symptomatic. And your risk is actually increased by the dose of the treatment, your age at treatment, with younger ages being more at risk. Female gender is also a risk, and then radiation. And there's a pretty clear dose-response relationship. So patients who receive only a small amount of anthracyclines really aren't at increased risk for development of heart failure. But the line here shows you about 250 milligrams per meter squared, and that's when your odds ratio for development of heart failure really starts to steeply increase. Okay, moving on. So a 22-year-old Hodgkin lymphoma survivor is seen in Survivorship Clinic. She underwent abdominal radiation as part of her treatment plan. She has just married her boyfriend and is wondering if she will be able to have children. Which of the following is most true about her risk for infertility? She is unlikely to be able to conceive a child at age 35. She is unlikely to be able to conceive a child. That's B. She's unlikely to be able to carry a pregnancy to term. And C, and chemotherapy is effective birth control. Okay. Wow, the different answers on this one. So you guys chose B, most of you, 36%. Actually, the answer is A. So most childhood cancer survivors are able to conceive a child and carry that child to term, even if they have had abdominal radiation. They are considered high risk pregnancy, no matter what their age. However, the lifelong fertile period is often shorter, as they are more likely to enter premature menopause earlier. So risk of infertility is one of the most common life-altering treatments experienced by long-term cancer survivors. And patients often are worried about their ability to conceive and have their own children as survivors of childhood cancer. The agents that are most often at risk for development of infertility are the alkylating agents, including cyclophosphamide, ifosfamide, and temodar, and then radiation to the abdomen, and definitely bone marrow transplant often renders these patients unable to conceive or carry a child to term. So fertility preservation really needs to be thought of before treatment for childhood cancer, and this is something that our department is struggling with right now. The best ways to do this for our patients, but really need to have the mindset that we can pause prior to treatment and think about fertility preservation, because that's really the one opportunity that you have to ensure that these patients are able to have their own children. And if they do survive childhood cancer, one of the things that impacts their life the most is infertility. So it's fairly easy for males with a sperm donation if they're post-pubertal. It's a little bit more difficult for females with the logistics of egg freezing or potentially ovarian preservation. But it does need to be completed prior to any chemotherapy. Even a single dose of intrathecal chemotherapy has been shown to significantly decrease the number of active sperm in a male patient. So these graphs are to illustrate that the risk of development of premature menopause is based not only on the alkylating agents, but also the radiation to the abdomen and pelvis. So you can see that there's a drop-off at about 30 years old with premature menopause. If you just receive alkylating agents, if you have radiation only, the drop-off starts at about 25 years. And then if you received both, most of those patients are infertile by age 30 or 35. This is an area that is interesting to me, so I just wanted to put in a few slides about this. As we're learning more about these cancer survivors, we're starting to realize that their phenotype is a lot like aging, actually. So long-term side effects, if you look at them all together, are similar to aging. So in the cardiovascular system, you can see cardiomyopathy, left ventricular dysfunction, which we talked about with anthracycline exposure. You can have valve dysfunction with that cardiomyopathy. With pulmonary issues, you can have pulmonary fibrosis, restrictive lung disease. And these are things that are more commonly seen in older adults. And then in the genitourinary system, you see tubular dysfunction, erectile dysfunction, hearing loss, and then the endocrine system, the premature menopause, osteoporosis, obesity and metabolic syndrome, hypothyroidism. Neurologic, you see more frequent stroke, cerebellar dysfunction, cognitive dysfunction, and in the liver, you see decreased hepatic function and intestinal obstruction. So all of these things, when you look at childhood cancer survivors as a whole, they tend to develop these symptoms at an earlier age than they would without having had childhood cancer. And this manifests as a product of their frailty or their ability to participate in physical activity. So 35-year-old survivors could only walk 550 meters in this study, which is more like the 55-year-olds than people their own age. So this is just one illustration of their overall phenotype. So I mentioned this a little bit previously, but I want to just illustrate this a little bit more fully. So I kind of think about these patients on a continuum. The treatments, the initial diagnosis of childhood cancer and then the treatments that the patients received really impact dramatically their risks of late effects. So in the low risk category, low risk Walsh tumor and low risk ALL, really don't have a lot of long-term side effects. Their mortality is not significantly increased. Their risk of infertility is not really increased. And they tend to live pretty normal and healthy lives after their diagnosis. In the moderate range are brain tumors, Hodgkin's disease survivors, any solid tumor that's metastatic at diagnosis, and then on the very high risk end of the spectrum, any patient who's gotten a bone marrow transplant, especially brain tumor requiring radiation, or a bone marrow transplant survivor who has had chronic and severe GVHD, those patients are going to be at very high risk for lifelong complications as a result of their treatments and sequelae. So I have three different patients that I wanted to talk about with these three diagnoses that I or my colleagues have seen in our survivor clinic since I arrived here in Phoenix in October. So these are real patients. The first one is BR. He is a 15-year-old male who is diagnosed with standard risk ALL at age 4. He completed treatment at age 6.5. His echo and EKG was done last year and was within normal limits. And based on his anthracycline exposure, he needs these screening tests every 5 years. He is a straight A student at Basis who would like to be a neuroscientist. His only late effects that he told me about were a slight tremor in his hands with intentional movement. So his handwriting is not that great. And on our recommendations, after talking with our nutritionist last year at our clinic, he lost a dramatic amount of weight. Actually, before we went in to see him, we were all worried that he may have a problem, but he just set his mind to losing weight and now has a normal BMI. So really doing very well. So luckily, BR is one of our low-risk patients, one of our low-risk survivors. He had low-risk ALL, and luckily this is our single largest group of survivors. So what do we worry about in this group of patients? There's not really that much to worry about, actually. They got low-dose anthracycline, so that they did not meet that cutoff for development, for high risk of development of heart failure. He didn't get any radiation. He may have some school difficulties that have been associated with intrathecal chemotherapy, but a large number of these patients, such as BR, really don't have any school problems. In fact, are excelling in school. And there's evidence that some of these survivors are at higher risk for development of metabolic syndrome, but with appropriate nutritional counseling and motivation on their part, they can have a normal weight and blood testing results. We do recommend a bone mineral density test at 18 years of age or so. They do receive quite a bit of steroids, which can thin the bones and increase your risk for osteoporosis. The Children's Oncology Group does recommend neuropsychological testing, a yearly CBC and UA, looking for secondary malignancies up until 10 years off therapy, and then that echo every 5 years. So this is a patient who's likely going to do very well. In contrast, this is another 15-year-old male that I saw recently. Initials are BA. So he's Native American. He was diagnosed with stage 4 alveolar rhabdomyosarcoma in 2004 at the age of 3. He received several courses of intensive chemotherapy without any significant tumor shrinkage. His mom was told to give up, to let him die, but she decided to travel to Minnesota to Mayo Clinic to get a second opinion. And the surgeon there was able to do quite a heroic surgical resection of the tumor and then high-dose radiation. He actually had intra-abdominal radiation with his abdomen open. He completed his therapy in 2005. He was later, unfortunately, found to have an undescended testicle, which received all that radiation in the abdomen and was later surgically descended. And he was seen in Survivorship Clinic in February. At that time, he was complaining of diarrhea and growth failure of the torso. He hadn't really been bothered by his short stature until this clinic visit, when he was enjoying playing basketball, but then noticed he started not growing in line with his peers, and his height was only at the 5th percentile. On his lab work, he was noted to have a high phosphorus level, and therefore he was sent to nephrology, and he was found to have grade 2 renal failure. A thyroid ultrasound was done because of his radiation, and it showed multiple nodules, but luckily the FNAs were negative for thyroid cancer. His bone age was done on the recommendation of our endocrine colleagues and was found to be normal for age, and therefore growth hormones not going to be beneficial for this child. He was evaluated by GI for diarrhea, which is now improving with the removal of lactose from his diet, and he has a colonoscopy scheduled. He was noted on exam to have very asymmetric testicles and was sent to urology, who will follow him. He will likely be infertile, but he's progressing through puberty now with a low normal testosterone level. Luckily, his echo and EKG and hearing are within normal limits. So he's actually doing fairly well, but he does have a number of health concerns that we need to keep on our radar, and this is someone who we need to follow very closely for development of late effects. So solid tumor metastatic diagnosis is at risk for many long-term complications. This, unfortunately, is a group where we're not as successful as we want to be in treatment, and so therefore we usually treat them with many high-dose chemotherapy agents in order to obtain a cure. Unfortunately, that leads to a lot of long-term side effects. Like this patient, they're likely to receive chemotherapy, radiation, and surgery at a young age, all of which can cause late effects. They may have growth failure, endocrine abnormalities, and chronic fatigue, and they need a wide variety of testing to be done with intensive screening, especially for secondary malignancies, especially in the radiation fields, including a dermatologic evaluation, colonoscopy starting 10 years off therapy, breast MRIs in females, and thyroid ultrasounds every 3 years. And then our last patient was actually seen in our bone marrow transplant survivor clinic. CH is a 14-year-old male who was diagnosed in 2010 with ALL. He had primary induction failure, which meant he never went into remission with our initial chemotherapy, which put him at extremely high risk of relapse. So he went straight to bone marrow transplant as soon as we could get him into remission. He's now 6 years post a matched sibling bone marrow transplant. His preparative regimen was total body irradiation, thiotepa, and Cytoxan. In the first 60 days, he developed acute graft versus host disease of his skin and upper GI tract. And 1 to 3 years off therapy, he had chronic GVHD, which affected his skin, his oral mucosa, his liver, his bone marrow, and he also had development of a pericardial effusion. He received 36 months or more of continuous immunosuppressive affecting both his T and B cells and 3 months of systemic steroids. And he has a large number of late effects, including chronic obstructive pulmonary disease with bronchopulmonary obliterans. And his FEV1 is only 25%. He may need a lung transplant. He is colonized with Pseudomonas. He has chronic renal disease. He has osteopenia and vitamin D deficiency, has vertebral compression fractures, history of iron overload, growth delay, education problems, doing poorly in school, adrenal insufficiency, and he also wears hearing aids. So this is a patient who is disabled from his treatments. And unfortunately, that's a proportion of our patients. Luckily, it's a rare patient. So what do we expect from survivors of bone marrow transplant? Well, the effects of transplant vary very widely, luckily, but more serious late effects can be expected in patients who have had chronic graft versus host disease, who are more sick prior to the transplant, or have more therapy prior to transplant, including more transfusions, and also patients who underwent TBI as part of their preparative regimen or total body irradiation. Pulmonary toxicities are much more common in this group of patients, and then endocrine toxicities, including growth failure and other hormone abnormalities, are very common. So these are examples of patients that we treat in our Survivor Clinic. And Survivor Clinics are very common around the country now, luckily, as awareness has grown of the specialized needs of these survivors. And our clinics, such as ours here at PCH, develop a survivorship care plan. And that's one of the primary goals of the Survivorship Clinic, which has details about the therapeutic interventions and their potential health risks. So this is an important document for both the patient and whoever takes care of them, either other subspecialists or the primary doctor who we partner with to help them receive the care that they need. It should contain personalized health screening recommendations and information about lifestyle factors that modify the risks. And the Children Oncology Group has a committee that develops guidelines developed based on the current literature and it's revised every 5 years and it's widely available. And the current recommendations look something like this. So this is from the 4th version published in 2013. So this is describing any potential late effects with radiation with a potential impact to the eye. And so the potential late effect would be cataracts. Risk factors include the radiation dose and TBI, and then recommendations for periodic evaluation and future health counseling issues, and then references. So each of these recommendations are personalized based on the patient's received treatments. And in our survivor program here, we see all of our survivors 1 time a year. That's our goal. And prior to 5 years off therapy, we are an adjunct to the primary oncologist. So we work with them to see them at least once a year. And right now we're seeing patients until age 18 or 10 years off therapy, whichever is last. And we do provide a binder with treatment details, information, and a book to first-time survivors. And then we do all the coordination for all the follow-up testing that I described. So this is what our survivorship program looks like here at PCH, and big group of people actually, and great group of people. So on Thursday afternoons, Britt Olson is over there. Camille is our nurse clinician. We have social worker, nutrition, and then Dr. Newburn is our endocrine liaison. So patients who come to the multidisciplinary clinic are able to see all of these people at one time, so it's very convenient for them. And we're able to discuss the patients and come up with a care plan often that same day. PCH Survivorship Clinic is its own entity, and Kristen, sitting next to Britt over there, is the lead for that. And Roxy, we have a counselor in that program, and then pulmonary physician comes up as well. Nephrology and social work, as well as nutrition come. And then we've developed a new clinic on Wednesday afternoons for the low-risk survivors to give us more opportunities to see these patients, which is just myself and then nutrition, social work as needed. And then we're still struggling or thinking about what to do about our adult survivors of childhood cancer. There's a big proportion of our patients who probably don't need ongoing care as they go into adulthood, but there's also a group of patients who could really benefit for that. So that's something we're struggling with, as a lot of different specialties are at this time. I looked at our data, so we have about 600 patients who have enrolled in our database collection. By far, the largest single group of patients is our ALL, acute lymphoblastic leukemia, with about half of the total. And then AML, Hodgkin's, and all the others that you would expect. I just wanted to spend a minute talking about our research participation, because I think that's an important component of our clinic and of survivor clinics in general, so that we can figure out not only identify late effects, but also start to think about ways to prevent some of these late effects. So we are participating in children's oncology group trials, which are open or are almost open. One of the ones that I'm most excited about is called Prevent Heart Failure, which is looking at low-dose carvedilol versus a placebo in patients who received high-dose anthracyclines to see if we can prevent some of these heart failure issues from happening. And then there's another study looking at high-risk neuroblastoma survivors with many, that's a unique group with many side effects, and then fertility and lymphoma patients. And we have about 800 survivors in our data set, which we're starting to look at various things in there as well. We're looking at iron overload impact. We want to do a survey of survivors who have aged out of our programs to see if they're remembering what we taught them, if they're getting the appropriate screening done. Looking at vaccine titer retention, and then there is an opportunity for other studies if people are interested. So in conclusion, in many patient groups of childhood cancer survivors, treatment intensity is decreasing, and this will hopefully lead to fewer long-term side effects in the future. And most childhood cancer survivors are doing very well, but there's an important subset with life-altering and chronic conditions. Overall, you can think about it as survivors overall age more quickly than their contemporaries. That's simplistic, but gives you an idea of the kinds of things that they have to deal with. And multidisciplinary clinics are very important to screen for and treat long-term complications. And there's exciting research to alter side effects in the future. And I just wanted to end on a picture. So this is a patient of mine who had Ewing sarcoma. He underwent a hip replacement, and he bicycled 5,000 miles and stopped in Las Vegas on his way around the country, raising money for childhood cancer research. So his orthopedic surgeon was not too happy with him, but he made it, and he's at UT Southwestern, wants to be an architect. So this group of patients is amazing, and it's a privilege to be able to help take care of them. Thank you. I think we have some more.